for bilateral multifocal disease. Similarly, it's unlikely for the patient, if we diagnose them as lobular, to go for neoadjuvant chemotherapy, but they are more likely to go for neoadjuvant endocrine therapy, and they respond really well to neoadjuvant endocrine therapy. In fact, very few cases that achieved complete pathological response after neoadjuvant endocrine were purely lobular, classic lobular. So sometimes it's difficult, I understand, and if you cannot make the distinction, particularly after you did ecadherin and beta-catenin, you might just end up calling it with lobular feature and wait for the excision. But on the excision, we need to make the distinction, and definitely we need to classify. But as much as you can, we try to make the distinction on core.
May I have a question, please? Excuse me, I have a question. First of all, thank you for all the speakers for this interesting presentation. I have a question for Dr. Abir regarding ADH and flat epithelial atypia. Regarding ADH, some of the clinicians don't do anything for ADH and they follow up the patient. They don't do surgery. This is one point.
If diagnosed on core biopsy.
Yes, they just follow up the patient. They don't do surgery.
Yeah, so generally we have moved from surgery in general. We try in the old times, we used to say B3 surgery, excise the whole thing. We've moved from that to just adequate sampling by vacuum-assisted excision. So that's what we do. In fact, in other parts of the world, they do surgery. I think most people would agree that there is a high chance of finding cancer if you sample a bit more after ADH. So you need to sample more tissue. Whether you do this by vacuum-assisted excision or surgery, but to leave it completely without anything, I don't think that's standard practice, and we need to do something, examine a bit more, because studies showed up to 40%, 40 to 50% will have cancer there. So we need to sample. I think we vary as to whether we would do VAE or surgery.
And for a flat epithelial atypia, you don't consider it in situ carcinoma?
No, flat epithelial atypia is a typical lesion. It's a B3 lesion. The degree of upgrade to malignancy is less than ADH, so it's around 11%. And we would also do vacuum-assisted excision. Also, I think most of the guidelines, the European, the UK, the German guidelines separate would recommend vacuum-assisted
And you don't use CK56 and ER, it will not help. It will not help.
They are negative. I think Dr. Shaheen wants to comment as well.
And also the role of HER2/neu in this.
I think one of the most important things in terms of management of ADH on core biopsy is based on clinical presentation and imaging findings. As we heard from Dr. Baumhower, it's very important to make the correlation with the imaging and the pathology. So if you have an ADH as an incidental finding, the biopsy is done for fibroadenoma. If the ADH is an incidental finding, that management of that ADH on a core biopsy is completely different than 5 centimeter of microcalcification and you found ADH on a core biopsy and that 5 centimeter area is suspicious. So it's really important to make the correlation with imaging finding before we say, what do you do ADH on a core biopsy? The clinical presentation and imaging findings are more important than the diagnosis.
And what about the role of HER2/neu in intraductal or fibroepithelial, intraepithelial lesion?
Yeah, that's a really good question. That's one of the times when we use HER2 for diagnosis to confirm. So if you have an intraductal proliferation, particularly if you suspect high grade or apocrine or so, and you do HER2 and it is strongly positive, this sways you towards DCIS.
Yes, to differentiate UDH from ADH and in situ.
Yeah, so we normally do ER and CK56 or CK14 because we normally use it in the low grade or intermediate grade category rather than the high grade. But HER2 is particularly useful in the apocrine proliferation, where you can't tell is it really a typical apocrine or and then if it is strongly positive, this sways you towards inside.
Thank you. Thank you.
My question to Dr. Daniel. There is always a great task to get an archiving of slides. And if you recall a case, for example, 10 years back, if there is any discrepancy between visualizing the slides as glass slides and the archives one, because I have to choose a certain field, a certain criteria to get a solid diagnosis in it. Is there any discrepancy? You can notice any discrepancy between the archived slides and when you review the the glass slide itself?
Professor, you're on mute. Please unmute yourself.
You hear my question, Dr. Daniel? You get my point? You are mute now. Mute. Connection, maybe? Connection? 5 minutes, 5 minutes, doctor. 5 minutes. 5 minutes, we'll come back. Okay? Just 5 minutes.
Any other questions? Okay. Okay. Go ahead.
Thank you very much for the nice talks. I would like to ask Dr. Sisley, please, regarding the metaplastic carcinoma. If we have spindle cell metaplastic carcinoma high grade blending with adenocarcinomatous component, and we prove that this is an adenocarcinomatous component by cytokeratins, do we still have to prove that the spindle cell part is also positive for the cytokeratins, or this is enough?
Thank you very much. So if you have a conventional carcinoma alongside a high-grade malignant spindle cell lesion, then the cytokeratin positivity is very strong in the carcinoma. Yes, absolutely, you have a diagnosis then of metaplastic spindle cell carcinoma. In fact, in that situation, it's nice to do the immunohistochemistry, but you don't really need it. If you have it coexisting, then that's a biphasic metaplastic carcinoma. The problem really arises with the monophasic, where we don't have the substantive evidence. Even if you have a malignant spindle cell tumor and you have accompanying DCIS, usually you would do the cytokeratins, but usually that's enough also for the diagnosis. Even if it is a metaplastic carcinoma with the dual components, you will find that the cytokeratin positivity is much stronger in the conventional carcinoma and very often very patchy and focal in the spindle cell component. Yeah, the P63 I think is a tricky one. I think it can be very useful. You can see P63 positivity in cytokeratin negative metaplastic carcinoma. So in that situation, it's supportive evidence of a diagnosis of metaplastic carcinoma, but it can be weak. There are clearly carcinomas, high-grade spindle cell tumors, which despite all the workup in immunohistochemistry, you don't come to a definite diagnosis. And actually, we both collaborated again with Ahmad Raka on a paper on this topic, actually published some time ago. And really the conclusion was at the end of the day that if somebody has a high-grade malignant spindle cell tumor and you cannot determine the lineage, that it's probably better to favor a metaplastic carcinoma because the therapeutic options are better. But clearly, I think context is the theme of the day. You've got to, take everything into consideration, make sure there isn't another tumor that you don't know about. No, again, I think that's also a difficult situation. If you have a squamous cell carcinoma in the breast, I think the first thing really is to bear in mind that you have 3 possible diagnoses. 1, that it is a metaplastic squamous cell carcinoma. 2, that it may have arisen from the skin of the breast. So you need to see exactly in the breast, is it in the parenchyma, is it in the skin, or where is it? And the third possibility is that it's metastatic. And I've certainly seen a metastatic squamous cell carcinoma from cervix presenting as a screen detected lesion. So when it comes, really, the immunohistochemistry is not hugely helpful in this situation because you will get the positivity for the P63 positivity, and the GATA also can be positive in either. Yes. So I don't find immuno to be that helpful in that situation, to be honest.
So we have to exclude that it is not metastatic.
Yeah, I
so
think-
it's not coming from the skin, and then
Yeah.
it is primary metaplastic.
I think that's really the start really at the beginning, and bear in mind the three possibilities, and then if everything else fails. Do you have anything to add to that?
Absolutely agree. GATA3 doesn't help. It can be positive in both skin and breast. So
Please-
don't rely on it. Look for connection to the overlying epidermis, dysplasia in the epidermis. Obviously, in situ disease or some.
needle core biopsy, so
yeah.
we cannot guarantee.
Exactly.
Thank you very much.
We are going to take two questions, one from the Professor Dr. Sana and one from Professor Dr. Shadja, and I think it's going to be the end.
Just a very simple question to Dr. Abir. If there is a difference between the two terms, flat cell atypia and columnar cell change, biologically and histologically? And just a very simple question for Dr. Muhammad. There are variants, special variants from invasive duct, which is epicrine, sebaceous differentiation, glycogen-rich, and lipid-rich. The four is very difficult to differentiate histologically. Is it important to differentiate from biological point of view or not? And if it is important, how on H&D only?
Columnar cell change, atypia. So columnar cell lesions, part of it, if non-atypical, we call it columnar cell change. So that's the non-atypical part of it. Okay. Can you hear me? Yeah. Okay. So columnar cell lesions will include columnar cell change that when there is no atypia. So no atypia at all, that's columnar cell lesions, or what we used to call as well columnar cell hyperplasia. So no cytological atypia, that's what we call columnar cell change, and it is B2. No problem with that. Flat. Yeah.
Can you hear me now?
Yes, we can hear you.
Oh, perfect.
Brilliant. So flat epithelial atypia is when it is flat or layered, we allow stratification as well, but with cytological atypia. And that's what the B3 category, and this one is the one that needs further examination. Yeah, flat is exactly, it's only atypia. Absolutely.
Okay, the other question is that about the special type carcinoma and the rare type carcinoma, the very rare type, the glycogen rich, the secretory, and all those. And the question is that, is it important to differentiate or just to say carcinoma or something? It is important to differentiate. Those are very rare tumors, and this is the whole topic. Okay, so this is very, you have to know this, the glycogen rich versus the secretory versus others. And there is a panel for this and some panels to help you in the differential diagnosis. At the end, if it is difficult, we call it invasive carcinoma, and we make a comment, and we can't specify the type. We do our best first. And the next lecture will be about the special type carcinomas. We'll talk about the metaplastic again, and all other carcinomas, and the squamous cell carcinoma of the breast versus the skin. So I have the question for Dr. Daniel here. Oh.
Yes, sorry, there were technical issues. Obviously, I don't know if I understood your question correctly. So archiving, of course, is in a digital archive much more easier than the conventional archive, because on the one hand, the slides and the sections remain in a very good state. Of course, they don't bleach out as they usually do over time, and you can easily retrieve them. So you don't need an extra technician who retrieves them from your archives. Currently, we're still also just beginning with the digitization, so we haven't a huge experience with that. Of course, you need a lot of storage space, but we know from our institutes that have been digitizing their slides for more than 10 years now, and it's really a great improvement to trying to retrieve old slides from the archive when you're undergone the digitization.
There is no discrepancy in some cases. No discrepancy.
No, I don't. No, I'm not aware that there should be a discrepancy.
Thank you. Shukran. Thank you.
Thank you, Professor Daniel. Please, Dr. Shadja. Last question.
Short question, Dr. Shadia, please. Short question.
I want to ask about the complex fibroadenoma. Is it considered as B3 lesion?
This will be covered nicely by Cecily.
The grading of lobular carcinoma.
Yeah, so the short answer is no, it is still benign B2, but it will be covered very well in Cecily's fibroepithelial lecture.
Grading of lobular carcinoma. The classic lobular considered grade 2 and, for example, the polymorphic variant is considered grade 3? Or, there is no grading for lobular carcinoma?
Very good question about the grading of the carcinoma. So it is, if it is special type, lobular, ductal, any type of carcinoma, we apply the Nottingham grade. So we go to see the tubule formation. Definitely for the lobular will take what? How many? What is the score? 3. Will take 3 because there is no glands. So for the lobular will take grade 3. Then you count the mites and you have the tables of the count, either 1 or 2 or 3. Then you go to the pleomorphism, the nuclear features, either 1, 2, 3, and the add. So the lobular carcinoma could be grade 1, could be grade 2, could be grade 3. But the question is that what is the most common grade? The most common grade by the WHO is grade 2. By the WHO is grade 2. This is the most common. Do we have grade 3? For sure. The very, very, very classic lobular, very classic. Some cells dispersed in the fibrous stroma, those usually are grade 1, are grade 1. Pleomorphic lobular carcinoma invasive, most probably will be what? 3, depending on the mitosis, because definitely 3 for the glandular, 3 for the nuclear pleomorphism, those are 6, and you're waiting for the mitosis, just to put you either grade 2 or grade 3. You count mite, and you count with Damir. You go and you count it. If it is in the first column 1, 2, or 3. So you need just a 2 in addition to the 6 to take grade 3. Signet ring is the same. We'll take 3 for the glandular and take maybe 2 for the new. Yes, so we'll take 3. It will take score 3. Then you go to look at the nuclei, most probably will be 2. So those are 5. Then you count the mites. If the mites 1, this will be 6, intermediate, and so on. So we do the Nottingham. We count mite, we see nuclear features, and any lobular will take 3 for the glandular. We'll take score 3 for the Nottingham score. Thank you very much. Thank you.
Thank you. Thank you very much. Thank you for all the speakers and attendance,
you.
and break for half an hour and back at 2 p.m. Thank you.